Hello. Uh, Today we are going to talk about clinical decision support systems. So this is not quite as practical for um, you guys now, but it's something that is good to know about if you're going to open your own clinic, or or even so you can know the history of clinical decision support systems in medicine and how we have gotten to where we are today. So the information is not very difficult today. I know some of the most recent lectures have been pretty technical, and so this one isn't quite as technical, so you can just relax a little bit more and uh, and just try to take in the main ideas here. So we're going to talk about clinical decision support systems, where we can use them, like the scope of them, like um, where in medicine we can use them, um, things that have make a good clinical decision support system and one that might be a failure. We're going to evaluate different decision support systems, and we're going to talk about how do people create these decision support systems, um, and then we're going to give some examples of early um, uh, decision support systems, and then talk about some open source examples, like ones that are free uh, that are available online. So, in general, when we talk about health informatics, this is really either where most countries are at or where they are going. Even like very poor countries are getting more and more um, electronic medical records. Um, and we see this even like with the Ministry of Interior here now, where for e-commerce you have to apply online now. Just everything is going to online. And so, whether this is in the medical system, for medical records, for scheduling, for appointments, everything is becoming more and more online. When we talk about coding and prescribing, coding means like after you see a patient, you write down a number, like what was their diagnosis, how long did you spend with the patient, and you send that to the insurance company, and then they give you money based on the code that you write down. Um, and we do this for drug prescribing. A lot of times we can just send a medication um, online to a pharmacy now, um, and then a lot of times even like the computer will tell us different drug interactions, or we might be using like a application on your smartphone to tell you, is this, do any of the medications the patient is taking interact. um, it's how we're starting to communicate with the laboratory. Like you don't talk to a person in the lab very often. They just, you send them the blood samples, and then they put in to the computer system the the lab results. Um, and a lot of times, even between the doctor and the patient now, there's a lot more that's just being done over email or through another platform. Um, Lastly, is a the where what we're more talking about today, which is clinical decision support systems, which are computer programs that help us with a variety of things, and we'll talk more about that today. And also, we talked some about this before, or actually, it's the next lecture, where we're talking about decision aids, like things that are going to help us make decisions for patients, and how do we compare data, different data with each other. Okay, so for this is what we're going to talk about today. Clinical decision support systems. We'll talk about the definition. We'll talk about different categories or types. We'll talk about how they are built. We'll talk about the good things about them and also the things that make a good clinical decision support systems. Um, we'll talk about areas where we can apply them and also some disadvantages. So first, a clinical decision support system is a computer program designed to help healthcare workers make clinical decisions. Um, so my definition for that, because like I always say, I don't want you to just memorize the words. I want you to understand what it's saying. So a clinical decision support system, in my words, would just be a computer that helps us in our work. So you can have your own definition. Um, so what they normally do is they take two or more items of patient data to generate specific case-specific device. Um, مثلا, like if we have a patient that is over 55 that smokes, maybe it will say you should examine the patient for COPD. That's the most basic thing. But maybe it could be you put in a patient is over 55 that smokes, he has a cough, there's bloody sputum, it's for 3 months with a fever. Like maybe you can put all of these things in, and maybe it will give you a diagnosis or a recommendation, or it depends on what type of support system we're talking about. But that's just an example. So the main components of a clinical decision support system, and this is important, this is the basic components, is that it takes in medical, or it has medical knowledge, like in the system, like built into the system. Um, and then there's patient data, so we put in the patient data, and then it combines these two things to give us a case-specific advice, like a specific advice on this patient. So there's a lot of different categories for support systems. One can just be a basic thing, like it can give you an alert or a reminder. مثلا زي the vaccine is due. Like, so if a child turns 2 months, the support system knows that the child is 2 months, and it will say, make sure you give this vaccine. It could be a health screening, like please check his prostate now. Please do a colonoscopy now. Um, if you want a patient to come back every month, it can remind you, hey, it's been 1 month. This patient needs to come back. Another category can be one that gives diagnostic assistance. So this is one that it suggests a diagnosis based on symptoms. زي ما حكيت قبل شوي, like the patient with a 50-year-old with that smokes, that has a cough, with bloody sputum for 3 months and weight loss, and then it will give you a one or more than one, most likely possible diagnoses. Another category would be something that critiques the therapy, or or helps you plan for what therapy to give, what medication to give, maybe what is the best medication to give, or for if it's critiquing the therapy, maybe you put in a medicine, but and you're sending it to the pharmacy, but since the computer already knows um, what other medications the patient is taking, it can tell you, are there any drug interactions or contraindications to this medication. The last category would be image recognition and interpretation. So this might be a computer program that gives you many different pictures of different rashes. And so if you have a rash from a patient and you type in, it's a red erythematous macular rash, it will give you all of these pictures, 100 pictures of different rashes, and then you can look which rash is the most similar to your patient, click on that picture, and it will tell you more about that rash. So here's some different ways that we can use clinical decision support systems. One is for information management. Two is for focusing our attention on something. Or three is patient-specific consultation. So the first one, tools for information management, examples for this would be hospital information systems, something like PubMed, like bibliographic retrieval systems, or specialized workstations like an electronic textbook. And so these are all different items that give us data and knowledge, but they do not help us apply that information to a specific decision or patient. And so, we can use PubMed, we can use any of the electronic textbook, we can use any other program that has information, but really, we're doing all the work on finding the information and then deciding, does this information apply to our patient, and if so, how does it apply? Another type would be something that would just help us focus our attention on something. Um, so an example for this would be a laboratory system that flags abnormal values. Yani like the abnormal values are red or black in bold print, or something that draws our eyes to the problem. Um, or maybe something that provides lists of possible explanations for abnormalities. Um, so, like if there's an abnormal lab, maybe it gives you different possibilities why this lab might be abnormal. So it's not telling you exactly what the problem is, but it's giving you some ideas of what to think about. A lot of times people will use these two in the pharmacy. So a pharmacy system might alert a provider to possible drug interactions or incorrect drug dosages. So if they type something in wrong, or if they think there might be a drug interaction with something the patient is already taking, this would help the doctor stop and think one more time, is this really what I want to prescribe or not? And so this is just designed to remind physicians of diagnoses or problems that might be overlooked. So it's not telling you exactly what you should do, but it's giving you, it's more focused than this. This is just giving you information. This one is helping focus your attention or remind you about some things that you might not be thinking about. Or the last one here is tools for a patient-specific consultation. And so this one is really providing customized assessment or advice based on the specific, this patient-specific data. So if we input, like I said before, like this patient with 50-year-old cough, sputum, 3 months, all this stuff, it's going to give us a few different diagnoses, and then also maybe, or maybe even provide advice about what tests or what examinations you should do, or maybe even give you treatment advice for what therapy is necessary, what medication, what surgery, something along those lines. So as we go down the list here, they just get more and more specific to that patient. So if we want to group the clinical decision support systems into different things, um, if we're looking at the system function, uh, sometimes we can so we can divide these clinical decision support systems in different ways. So if we're looking at just how does the system function, a lot of times it's in two groups. So is it determining what is true about a patient? Like, is it giving us what the correct diagnosis is? Um, or is it determining, or is it helping us in what to do? So is it what is correct, or what should we do? So what to do would be an example would be what test should we order? Should we treat or not treat? Should we do a surgery? Should we not do a surgery? What medication should we give? Something along those lines. And so if we're looking more at how are they giving advice, we can look at is the decision support system playing a passive role or is it playing an active role? So the difference between these two would be in the passive role, the physician uses the system when he wants advice, but the active role for the clinical decision support system is that it's going to give advice automatically um, under certain conditions, whether the physician wants it or they don't want it. It's just going to give them the information no matter what. So in a passive system, the physician has ultimate control because first of all he decides, do I want advice? And then so he uses the clinical decision support system, and so the system will give him advice, and then he analyzes that advice and decides whether he wants to accept or reject it. So a lot of times we will use something like this in a really wide domain, like all of internal medicine. Um, and so, like if we want to just be using this for patients in general, for all of our patients, we could use it for that, just in general for internal medicine. But sometimes we could use it for a really narrow domain, like a patient that has acute abdominal pain, or when we're analyzing an ECG. Do we want the computer to help us with the diagnosis, or do we not want to have it help us? Um, there are actually some ECG machines that they will always give you the diagnosis, or no matter what, or its own, or it will automatically give you its recommendation. Other ECGs, you might have to tell them, yes, we want you to tell us the information. So an active system, we would say that the user or the physician has partial control. So the system is giving advice without being asked, so automatically. But the user or the physician or the nurse or whoever can still evaluate that advice and can still accept or reject that advice if they want. Like they don't have to obey it, but they are going to get that advice um, without asking for it. So we use this a lot of times because we can't use a system like this for every single uh, patient, like automatically. Like we're not always going to be inputting this, but um, for this, we can use it. It can really be a part of the system that's built in that it can always give you advice. So, like for example, if we're talking about drug interactions, if the computer knows all the drugs the patient is taking, it's going to always give you what um, adverse drug interactions there might be. Or it can always tell us, are we conforming to the protocol that the hospital has set up or that the Ministry of Health has put into place? Um, and we also can use this for when there's, um, like we said before, if there's a lab result, we can just tell the computer to um, always show us in red if there's a lab value that's abnormal. Um, Also, if there's certain medical devices, maybe a medical device might give a warning, like if there's a ventilator and there's a problem with the tube and the air is not going in and coming out well, um, uh, it will. We can set the computer to automatically give an alarm if there's this type of problem. So um, so in some instances, this active system would be great. Like we don't want the doctor to have to ask the computer is there a problem with the tube on this ventilator? We want the computer to automatically tell us if there's a problem. But with these patients, a lot of times we don't want to type all of our information into the computer every time and ask the computer what it thinks about every patient. Like in the clinic or something, if we do that every time and ask what is the diagnosis for every patient, um, and maybe we know it's just a viral cold or something without needing the computer's advice for that. So some advantages for clinical decision support systems is that there's really been an explosion of information. 70 years ago, we only had one antibiotic, and now we have thousands and thousands and thousands. And so, um, and the amount of research we have is just exploded. There's so much out there. It's impossible now for one person to keep all this information in their head. Also, like one thing that's an advantage of this is that it really helps us provide, it standardizes care. And so if we want to make sure that all doctors are at least doing a certain level of care, giving a certain level of care to their patients, we can use these systems to help doctors that might not know this information. Maybe some doctors might know to do a colonoscopy for everyone after 50 years old, but maybe some doctors didn't know that. Maybe some doctors forgot. But by having a clinical decision support system, this helps us provide a, a certain standard, a minimum standard of care for every patient. Um, I, One thing too is that we don't always have a lot of time to go and read and go and study. And so, if we have a good decision support system, it can give us information automatically without us having to, for example, go check the ventilator every 5 minutes to see if it's working. Um, so, a lot of doctors have been trained in different ways. Some of them are very lucky and they got trained at Hashemite University, but other people, maybe they got trained somewhere else in Jordan that was not as good as Hashemite University. Um, and so, um, so it helps us standardize their care even if they didn't have the same training. So it can also help us apply evidence-based medicine rather than a doctor just deciding that, hey, like steroid injections are good for to give to patients with allergies. um, we can apply evidence-based medicine and say, hey, actually, something like loratadine or cetirizine, that's actually a better medicine for uh, seasonal allergies, and so we can set it that if a patient or a doctor is treating for a patient for seasonal allergies, it will remind him that saying, hey, steroid injections are not a good treatment for this, but first line treatment would be loratadine or nasal irrigation, something like that. So we can help doctors be reminded of the evidence based medicine. Some possible disadvantages of this would be is it does kind of change the relationship between the patient and the physician. Um, More so because it's like the computer is helping with the diagnosis or giving recommendations. And so maybe a doctor might rely too much on that and not think critically. Does this really apply to the patient? Or he just might not even be trying to think. Like he's just going to be waiting for the computer to give him the problem. And like if a lab, even if a lab value comes up um, wrong, the doctor needs to decide like, okay, was the sample taken correctly? But maybe a doctor would just always rely um, on the lab when we know there is lab errors sometimes. or we know sometimes that the information might not apply to a certain patient. And so that's a possible disadvantage, is that maybe a doctor will not be thinking as critically to help solve a problem. Also, when we think of legal implications, if a computer gives a the wrong diagnosis, and then the doctor accepts the diagnosis, who is at fault? Is it the computer? Is it the person who created the computer program? Is it the doctor because he should have known better? Um, so that's kind of an interesting thing too, like that. Um, if there's a problem, who has the final responsibility, and who would be the one that would be getting sued if there's a problem? So when we're talking about a clinically useful decision support system, we're wanting a decision support system that's based on the best evidence. We don't want it to be based on evidence from 10, 20 years ago. We want it to have as much knowledge as possible, and a knowledge that fully covers a problem. It can't be something that's a very basic thing. If there's only 5 possible diagnoses for cough, we know there's many, many more possibilities than that. And so it's not going to be very clinically useful. We want the knowledge to be able to be updated. As we get new evidence, we want to be able to update the knowledge. If in the computer program cannot be updated, then it's not going to be very useful after a couple years. We want its performance to be validated. Like we want this decision support system to have been studied well, and we want the evidence to show that it is a good, reliable system. We want to make sure that this is actually improving clinical practice. If it's not improving clinical practice, it's kind of a waste of time. Like it'll probably just slow the doctor down. Um, so we want it to actually be able to um, improve the level of care the doctor is giving. We want the doctor to be able to be in control. Like we don't want the doctor to be on autopilot. Like we don't want him to just um, be forced to make a decision based on the results. We want the decision system to remind him about things he might be forgetting, or give him possible recommendations or advice, but then he has to use his judgment and his or her expertise to decide, does this really apply? Does this make sense? We want the system to be easy to use, because if it's not, no doctor is ever going to use it, because it will just be um, maybe a lot of doctors aren't used to computers, or maybe they're too busy. So it needs to be very easy. And the decisions or the recommendations, they need to be clear. It can't be a confusing result that the decision support system is giving. So when we look at early decision support systems, one of the first ones came out in 1972, and it was just for acute abdominal pain. It was using the Bayesian approach, so some of those statistics that we were talking about before. Um, and it was helping a doctor figure out what was the cause of this acute abdominal pain, um, uh, especially trying to rule out things like appendicitis, diverticulitis, something like that, based on the information that the doctor would input into the system. Um, in 1974, one was created, Internist 1, um, that was a little more complicated. It was a rule-based system, and so meaning that if you put in certain problems that the patient might have, it would take you through a pretty um, complex algorithm to um, to create a list of possible diseases. So here, maybe it just um, gives you the most likely in this one area, but here it would be kind of any symptom the patient is having, and then create a list of possible diseases that might go along with those symptoms. Um, in 1976, this is a pretty famous one here, Meissen. Um, it was a rule-based, come on, it's another rule-based system designed to diagnose and then even recommend treatment for certain blood infections. And so you can see it just getting a little more complicated. So here it's about one topic. Here it's about multiple topics, but still giving you a diagnosis. Here it's a it's a very broad range that you can use it for. It's a very wide domain. Um, and then also not just diagnosing, but giving recommendations for treatment for certain blood infections. And then it was extended to handle other infectious diseases as well. So it was set up as a set of if-then rules um, with certainty factors attached to the diagnoses. So, for example, it would give you something like this: if the patient's age was less than 55, um, and the duration of symptoms was between 3 and 113 days, and the duration of other rheumatic diseases was less than 13 days, the number of swollen joints less than 3, if the spinal pain seemed like it was spondylotic, um, all these things, then it would say the diagnosis is degenerative spine disease. Um, but if the patient was female so it would give you, if you put in information about the patient, about all these different types of things, the number of painful joints, what type of spinal pain were they having, how long has the patient been having symptoms for, any skin manifestations. You'd answer all of those. What is the patient age? What is the patient's sex? Um, then the computer would give you a final, most likely diagnosis. So this is, I mean, it gets very complicated, but so this is one of the examples that it would give. So if all of these things applied, so if the infection requiring therapy was meningitis, so you know it's meningitis, if there were no organisms seen on the gram stain of the culture, if the type of infection is bacterial, if, then it says the organization that might be causing the infection are these types of bacteria. Um, so obviously that took a long time for someone to input that, but all the doctor needs to put in is to answer some of these basic questions, and if they are true, then or false, it will give a certain result. These ones in general were not very, the early ones in general were just not very user friendly. This one, DXplain, it's like explain, but it's kind of a play off that. Instead of explain, it's like diagnosis explain the diagnosis. So DXplain is it uses a set of clinical findings like signs or symptoms or lab data to produce a ranked list of diagnosis. And so instead of just giving you one diagnosis or a list of possible diagnoses, it gives you a certain list. Like most likely is this diagnosis, and then this is second most likely, etc. So it has over 2,000 diseases and 5,000 symptoms, and it also gives you justification why each of these diseases might be considered. Um, and then, so it would say like, okay, this disease is more likely because of this. Um, this is most possible disease because of this. Um, so, like if the possible diagnosis was COPD in a patient with cough for 3 months who smokes, who has bloody sputum, we might say, well, lung cancer is possible because this patient also has a bloody cough. The next one might be just a COPD exacerbation because this patient has smoked for a long time, and he also has a fever, and it's been going on for several months now, something along those lines. Okay, and then it also suggests what further information um, might be useful. So it might say, but maybe if the patient has this or this, maybe this diagnosis would be more likely. So then you can go back to the patient and ask them, do you have this problem or this problem? This is what it looks like. It's still around today, so some people might still be using this, although it's a little old now. So you kind of might enter some findings here. It's going to ask you, then you submit it. It's going to pop up. It's going to ask you some questions if they have any of these things. And then it's going to give you a list over here of common diseases that might cause this and rare diseases that might cause this. Um, and you could still actually look it up on this website if you want. And then if you click on this here, it's going to give you more information about the disease. Another one is QMR, Quick Medical Reference. It was based off that Internist One software that we talked about, one of the early ones. And it's another one, it's a knowledge base of diseases, diagnoses, exam findings, disease associations, lab information, and it contains medical literature on 700 diseases and 5,000 different symptoms and signs in labs. Um, so it would look more something like this. You can see that this is still kind of pretty old, um, an old decision support system. But so if you're putting in all of these things, this guy has age greater than 55, male, he has substernal chest pain, he smokes, all these different things, and then it can kind of do the same thing, give you the most likely diagnosis and also other possible diagnoses. So then if we put in his information here, then we get something like this. So we have that it's most likely an acute MI, also possibly just angina. Um, uh, he has obesity. This wouldn't cross out this, but maybe he has more than one diagnosis. Like, and of course, like we know he has diabetes, so like that's a part of his diagnosis too. But so um, maybe he has just one of these. Maybe he has more than one of these. So there's some open source medical decision support systems as well. Um, uh, a lot of times these are systems that um, all of these systems really you don't just go online and use the system. It's not like UpToDate or PubMed or something like that. These are all systems that you would use if you're opening a clinic or maybe a hospital that you're working at has a certain clinical decision support system already set up in it. It's not something just to use on your own, um, like at your house. Like this is a whole uh, software system that they've downloaded onto their computers to help them. We talked about evidence-based medicine before, where we can use UpToDate or PubMed or Medscape or something along those lines. That's more for when we're doing our own research. This is what we're talking about here is more of a support system that a medical clinic or network or hospital is going to use. Um, so here, for example, in this EMR, you have a drop-down menu. Um, you put in all his problems. You have a place to save all his electronic medical record, really, his family history, his social history, and then it's just always saved there. So you have all his past medical history saved here, and then you have any new symptoms, and then it's going to possibly give you something like this. And this is just one part, but so this guy's over 50, and it's saying there's no record this patient has had colon cancer screening in the past 2 years. Do you want to order this or not? So we can just ask the patient, can I order this for you? If he says yes, we can click on please order now. If not, we could say declined or remind me later or something along those lines. So it was interesting. So some of this information I was getting from Dr. Tamimi. And so, in the last time he taught this course was in 2014. And so, this was some of his information here about from 2014 is that in 2014 is that there was 70 known proprietary, yani is a decision support systems that had a patent on it or that companies had created. So, really, like 70 clinical decision support systems, but they were only designed for general practice and they required really advanced technical knowledge to be able to use them. And they were mainly developed with little consideration for the user, like maybe a scientist or a person or a IT professional was creating it, but wasn't really thinking, is this very usable for a doctor? And so, really, at that time, systems had failed to gain wide acceptance by physicians. And now we are just 6 years later, and really almost every healthcare system uses some form of um, uh, decision support system. Um, I mean, even small clinics. At the Norwood clinics in Jordan, they just started having uh, all electronic medical records about 2 years ago. Um, I mean, even every hospital in Jordan has the lab system is based on a computer system now. So almost every healthcare system uses some form of decision support systems, um, especially in things like the pharmacy. Um, in certain countries, the billing, like I was saying, like how we code for what we're seeing, and then how we're deciding how much is the cost of a patient's stay in the hospital, or how much does a patient's visit to the clinic cost. Um, and also, especially a lot very common is vaccination and screening reminders, like we talked about. So these are the ones that are, I mean, they're almost universally used by everything. And then in more developed countries, just the entire electronic medical record is 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 on the computer now. Like the paper charts are really going away. So when we talk about the electronic medical records or EMR, um, this is uh, saying like all like the patient records are electronic rather than a paper or a chart um, or a paper chart. Um, so the nice thing about them is that the data can be accessed by clinical staff at any location because it's all stored in the computer. Um, for insurance companies, this helps because they don't have to just look through a box of papers or they don't have to rely on the memory of doctors and nurses. They can just look in the computer system what was done and then they can decide this is how much it cost. Um, they're really helpful for, like we said, automatically checking for drug and allergy interactions. This has helped me many times. Like I'll, write someone for amoxicillin, and I just forgot to check to see if they're allergic for amoxicillin or not. And the computer tells me, hey, like they're allergic to this, and so I changed it to something else, and it prevented a medical error. Um, so a lot of times, like I said, like the clinical notes can all be done, and so they're not going to get lost because they're all there in the computer. Um, for a lot of times, we can just um, send a prescription to the pharmacy directly, so the patient doesn't lose the prescription, or so that there's no one can forge the prescription, um, or no one can miscommunicate the prescription, and they can, the pharmacy can just have the prescription directly from us. Also, with more and more, scheduling is done this way rather than just in a little book. Now, scheduling can be done on the computer. Um, and then also, when we're asking to see lab results, they can all just be brought up on the computer very easily. So those are all the advantages there. Um, uh, the disadvantages, if we're talking about paper records, is that, man, where do we store all this information? Like, I remember when I first came to the police station in Jordan and I saw all of these paper charts in the back. I just thought, how would they ever not lose things? Like, they have to be losing things all the time. But hopefully, with an electronic record, it's much easier to look up. So, disadvantage of paper record would be it's just so hard to organize when it gets to be too much information or too many charts. Um, Logistical, maybe the wear and tear, um, like papers get old, they get ripped, they wear out. Um, Also, it's only in one place at a time. And also, it's hard to have backups unless you've literally printed off copies of all the charts. If the paper gets lost, it's never coming back. So that's a real problem. Um, uh, but at the same time, some disadvantage. Oh, I was going to say here, research, Yanni, is if we have a research paper written, but it's not available on the electronically, it's going to be really, really limited on uh, who it who can be reading the information. Disadvantages of electronic medical record is sometimes there can be a lot of information and it can be hard to find it because everything is being saved. And so, I mean, sometimes, like for one uh, patient visit to a clinic, it can be 10 pages or something um, of automated information that has been put into a patient's chart. I don't know if you've seen that before, but it can almost be easier sometimes just to have a paper chart and flip through all the papers really quick rather than uh, try to find all the information. I'm finding that with your guys' homework right now is that it's nice because it's all, I'm not going to lose your homework because it's all in Microsoft Teams, but I can only see one page at a time on the computer, and every time I want to skip to a different page, it takes a few seconds rather than if I have a paper chart. If I had all your homeworks in paper, I could just flip through it a lot quicker. Another disadvantage is that a doctor, has to be computer literate to be able to use it. If they don't understand how to use a computer, it's going to possibly make their care slower and even worse to a patient. Um, Also, it can create a barrier between the doctor and a patient. Now that in America, uh, the doctor is a lot of times putting all of the information into a computer, he might be looking at the computer the whole time rather than looking at the patient and talking to the patient. And so the computer can even be something that's in between the doctor and the patient physically. Um, Another thing would be power outages. If you have a laptop, maybe that's not such a big deal, but if it's not, um, uh, uh, maybe like the computer system goes out and now you've gone from all this information to no information. When we talk about different types of electronic medical records, one type is we talk about a born digital record, and that's a record where the information was originally entered in electronic format. And that's in contrast to the digital format record, where that was originally produced in a hard copy. Maybe this is a photograph the patient has taken, or like an old photograph, like before, not a digital photograph, or a written note, or maybe it's just old medical charts, but now they've been scanned um, into a digital form. Um, that's a lot uh, more confusing, honestly, because you can't, like, if you just scan a picture, you can't necessarily like search for keywords, or it's not in the system and not linked to the system the same way as something that's originally be entered as an electronic form. A personal health record would be a health record stored and maintained by the patient. Um, and so this is great for the patient because if they go to different doctors, they can always have this with them, um, maybe on a USB drive or on their computer. But a home computer is generally more vulnerable to attack, like a cyber attack, than a hospital system because the hospital system normally is going to have more security uh, in place. Um, there is this is kind of an aside, but um, when we talk about maintaining records, that's something that all hospitals are required to do. In uh, in different places, it's a different amount of time, but sometimes it's 7 years, sometimes it's 15 years, and sometimes it's even many years after a patient's death. Um, and so we really need, because this is private information, we really need a lot of privacy and security policies to be in place. Um, uh, One problem with this, and something that makes this difficult, is that if we don't have enough storage space on our computer system, we might outsource this or have a different company store the information, and then we don't know like what is their privacy and security policies. And so if other people are accessing the patient information, um, then uh, this is really a breach of confidentiality. And in some countries, like a patient can sue the physician or the hospital if their information were to become if someone else were to access their data. Um, so when we look at this example here, this is the National Health Service project in the UK. Um, and this is, like I said too, this part I got from Dr. Tamimi. It was one of the largest projects in the world for a countrywide electronic medical record at that time. They had a goal that by 2010, so in the early 2000s, they set this goal to have a centralized electronic medical record by 2010. But in 2011, The Guardian, one of their magazine, um, kind of published an article saying that the Department of Health is not going to deliver this program that cost $11 billion. And really, they said it's been unable to demonstrate any benefits for the taxpayer. So they were really seeing at this time this has not been a useful thing to to develop an electronic medical record. And so MPs, their parliament, said the intention of creating an electronic record, it was good, it was a worthwhile aim, but they just haven't been able to prove that they're going to be able to implement this. And so, in general, many companies that were trying to help with implementing the electronic medical record walked away, and they decided, this wasn't it's not worth it. It's not worth the cost. When we're talking about our cost-effective analysis, that's what they were definitely using, and they decided, the benefit that we're going to get is not significant enough to justify the cost that we are spending. So I thought that was really interesting because if we look now in 2020, so we're just talking 6, 9 years later, the project actually has continued to move forward, and now 94% of institutions in the UK have some sort of electronic medical record. It's taken a lot of cooperation with physicians and hospitals to get an electronic medical record that would be cost effective, that would be user friendly, that would actually be beneficial. Um, but one thing they had to do is we call this, I don't know if you've heard of this before, and they've done the same thing in America, is that using a carrot and a stick. And so if you have a hamar, a donkey, and you want him to move, sometimes it's good to hold a carrot in front of his mouth because he might walk 1 or 2 steps because he wants to eat the carrot. But sometimes you need to use a stick and just whack the hamar on the back to get him to move. So we call this the carrot and the stick. And so sometimes, like in this project, they had to give incentives to doctors um, in clinics and hospitals to implement an EMR. Maybe they would give them tax breaks or reduce their taxes if they reduced or if they used an EMR. Or maybe they would give them a bonus check or some extra money if they were to use an EMR. But maybe sometimes the country had to use a stick and say, if you don't have it implemented by 2020, then you are not going to be able to see patients anymore at your clinic. Or we're going to start fining you or charging you every week that you don't have it implemented. Um, but I thought that was fascinating that these clinical decision support systems, they started and they were not very strong, and then we really started seeing the importance of them around the year 2000. Um, but when we tried to start implementing them, it was so costly and such a big deal and just wasn't very helpful. But when we kept trying and trying and trying to improve them, we're finding now that it is beneficial. And now, in a lot of electronic medical records, a lot of the information is this born digital now, whereas at the beginning, it was a lot of the stuff was just scanned in from old patient charts. So now that we have more and more born digital records, it's becoming more and more useful to doctors and clinics and nurses and hospitals to be able to have these support systems. Um, Okay, that's about it. Like I said, this is not as technical, but it's just good history to have, and uh, just I want you to know in general some different types and some different uses for decision support systems, and the type of decision support systems that are good. And so, if you are opening your own clinic or you are on a board of a hospital or a clinic system, and you're deciding what type of decision support system do we want to start using, or how do we want to change our clinical decision support system now, that you have an idea of just some background information on what might make a good decision support system. All right. Thank you very much. Let me know if you have any questions.